A hearty good evening and welcome to a session on recurrent implantation failure. We are glad to have Dr. Sangeetha S. Anand among us today to help us explore this topic. The cause of implantation failure and are diverse and usually due to different material factors as uterine abnormalities, hormonal or metabolic disorders, infections, immunological factors, and more, and even some less common ones for that matter. The doctor will take us through this and help us better understand what this means and how we can try for a successful pregnancy. Doctor, you have the stage.
Thank you. Good evening. This is Dr. Sangeetha Anand, consultant reproductive medicine at Apollo Fertility, Brookfield, Bangalore. Today, I would like to discuss about recurrent implantation failure. IVF failure is very common nowadays. It causes a lot of stress on the couple as well as on the patient. There are a lot of questions and no clear answers sometimes. Patients blame themselves for the failure. They think that the IVF failed because they did something wrong, they did the exercise, they did some kind of food which went wrong. They have a guilt feeling that the body rejected the embryos. After an IVF failure, it becomes a burden on the doctor as well. Although we know that the success rates are only 40-45%, people expect results in the first cycle. So after a failed IVF, it is the responsibility of the doctor as well as to patient to discuss and find out what went wrong. Can it be changed in the next cycle? So we need to troubleshoot. So troubleshooting means we find out from each part whether it is from the endometrium or the oocyte or the sperms or it's a multifactorial cause. So troubleshooting, we look at first the ovulation protocol. What superovulation protocol was followed? What kind of drugs were given? What was the patient's response to the dosage of injection? And how many eggs were retrieved? How many were mature eggs in it? And this is about the clinical part. Next point will be looking at the laboratory parameters. What was the fertilization rate? What was the embryo quality? What was the sperm quality? Whether IVF was done or ICSI was done. This is how we troubleshoot and find out. So many a times we are able to find out some reason, and many a times we don't find the reason. What is recurrent implantation failure? When there is a failure of a embryo to implant inside the cavity, even after two failed IVF cycles, when four good quality embryos have been transferred, then we call it a recurrent implantation failure. So, recurrent implantation failure means when there is a failure of a embryo to implant, even after two consecutive IVF cycles, where four good quality embryos have been transferred. So, it is a condition which causes distress to the patient as well as to the doctor. In this topic, we will talk about the introduction, Then what are all the various causes or the repeated failures, what investigations we do, and how do we treat them. There is no universally accepted definition, but as I said, when there are a failure, multiple failures of even after transferring good quality embryos, if the patient doesn't conceive in a young patient less than 40 years of age, we call it as recurrent implantation failure. So it is seen in about 10% of the patient who undergo IVF. As I said, it causes frustration to the doctor as well as to the patient. It increases the cost of the IVF treatment to the patient, and it becomes a challenge to the obstetricians, I mean the fertility specialists as well as to the embryologist. Looking at the etiology, the main factors which contribute to pregnancy are, as we know, egg and sperm. Next is the endometrium, and next can be a multifactorial, like many factors can contribute to it. First, looking at the uterus, when there are endometrial factors, endometrium is the inner lining of the uterus where the embryo sticks to it and starts to grow. Any anatomical defects in the endometrial cavity, like a polyp, that's an extra growth inside the lining, or a fibroid which is distorting the cavity, or adhesions because of any chronic infection inside the uterine cavity, or a septum. These are all anatomical defects which can prevent implantation. Next, when there is a thin endometrium, there is a certain thickness which has to be maintained to achieve a implantation. So, a thin endometrium as well as a thick endometrium can prevent implantation. Because of thin endometrium, there can be an altered expression of adhesion molecule. Next, there can be inherited thrombophilias and some immunological causes which contribute to the implantation failure. Next, going to the gametes. Gamete means sperms and the oocyte. Any chromosomal abnormality, poor quality oocyte, poor quality sperms can contribute to the failure. Next is zona hardening. The outer covering of the egg has a shell called zona. When the zona becomes thick, then it can prevent the embryo from attaching to the uterine cavity. Next, the lab culture condition. When there is a suboptimal culture conditions in the lab or a suboptimal embryo quality, that can also have an impact on pregnancy. Next, the embryo transfer technique. When a traumatic embryo transfer is done, when there is a blood tinge in the embryo transfer catheter, difficult transfer, again it can have an impact on pregnancy. Next, the multifactorials. Other than the egg and the sperm and the uterus, there are other causes which can lead on to failure. One is endometriosis. Endometriosis is a condition where there is a collection of menstrual blood other than the uterine cavity. It has an impact on every stage of pregnancy towards pregnancy. Next, hydrosalpinx, swollen fallopian tubes, because that fluid can be toxic to the embryos and it can flush out the embryos. So, hydrosalpinx, which was not detected in the first cycle IVF, can also lead to a failure. Next, suboptimal ovarian stimulation, the dosage of the drugs what you give and how many days stimulation, what was the estrogen level, so many factors play in superovulation protocols. How do we investigate when there is a repeated failure? We sort out where could be the problem. First, we look at the uterine cavity. If there is a suspicion for a intrauterine pathology, then diagnostic hysteroscopy can help us to find out any issues with the uterine cavity. Next, if there is a uterine anomalies, either a transvaginal 3D ultrasound or an MRI can help to find out the uterine anomalies. Next, HSG can find out the hydrosalpinx. Next, when there is a suspicion for a immunological cause, then we check at the natural killer cell activity in the endometrial cavity, and we do other screening for APLA, SLE, and thrombophilia. All these factors, autoimmune condition, can have an impact on implantation. Next, going to the embryonic factors. Checking out the oocyte quality, ovarian reserve. Age of a woman plays a very important role in deciding the oocyte quality. So, as such, age beyond 38 years of age, they tend to have a poor quality oocyte. The chances of having aneuploid embryos. Aneuploid means abnormal set of chromosomes in the embryos goes high as the woman's age crosses 38 years. So the basal FSH value, the basic hormones tested on second or third of the period, anti-Mullerian hormone levels, and antral follicle count, these are all done to exclude any significant compromise on the ovarian function. That helps us in counseling the patient. when the age is more than 38 years, when the AMH is low, previous history of miscarriage, high FSH, and low antral follicle count. All these will help us to counsel the patient that they should have realistic expectations on the results. Because when the age is more than 38 years, definitely the oocyte quality might be compromised. So they should know that IVF in the first cycle itself might not be a successful one in these kind of patients because of the low ovarian reserve. Next, going to the semen quality. Looking at the, even if the sperm count, motility are normal, sometimes there can be DNA fragmentation happening to the sperm, which can lead on to a negative result. So the DNA fragmentation index more than 27% can also lead on to recurrent implantation failures. Next, going to the karyotype. When there is an advanced maternal age, as I said, the AMH might be on the lower side. When there is a poor ovarian reserve, then at a young age, it's better to check at the karyotype to rule out any structural anomalies in the chromosome. When you see patients like that, pre-implantation genetic diagnosis can help to achieve a good result. Next, going to the treatment part, when there is a repeated failure, so we need to individualize the treatment, and it has to be a multidisciplinary approach where you need to have a experienced embryologist and a fertility specialist, and we need to discuss with the patient to find out what could be changed so that we can achieve a result. What could be the reason for the failure and try to correct the issue. Change the protocol. So individualized protocol for each patient. As I said, first look at the uterine factors, then look at the gametes, then look for thrombophilias and immunological causes. First, like correction of the uterine anomaly. When you suspect a fibroid or a polyp or adhesions or a septum inside the cavity, hysteroscopy, diagnostic hysteroscopy is the procedure of choice to find out any issues within the uterine cavity. Hysteroscopic, if you suspect a septum, then the hysteroscopic correction of the uterine anomalies. Or if there is a fibroid which is distorting the cavity, then removing the fibroid. These two can help to improve the chances of pregnancy. Next, going to the endometrial function. If you see a thin endometrium, if you could not achieve a 8 mm, 3-layered line with a good blood flow endometrium, and you had to transfer the embryos at 6 or 7 mm, then we need to look at the reasons for the thin endometrium, how to improve the uterine blood flow. We give Dolores aspirin, we give vaginal sildenafil, and if the endometrium is not good in the stimulation cycle, then all the embryos are frozen, and the endometrium, once it grows as 8 mm, then we plan a transfer by giving exogenous estrogen supplements. Instead of oral, you can even use a vaginal micronized estradiol tablet, which can give a better endometrial thickness. Other supplements like antifibrinolytics, high dose of vitamin E, pentoxifylline, all that have been found to give a good endometrial thickness. Next, going to endometrial scratch. Endometrial scratch or endometrial coring is a procedure which is done in the cycle preceding to the actual embryo transfer cycle. It is usually done 7 days prior to the onset of menstruation or immediately on the day of starting the IVF stimulation. In the follicular phase of the same cycle, it doesn't have much impact. But if it is done during the oocyte retrieval time, again it decreases the clinical pregnancy rate. So you need to do one cycle prior to the month when you're planning the embryo transfer. What we do is we just use a Pickel catheter and scrape the uterine lining. So it's like a biopsy, just like a hysteroscopy. It's like a mini hysteroscopy. They found that the clinical pregnancy rate almost doubled after a endometrial scratch. The clinical pregnancy rate was twice as high as biopsy or a scratch as opposed to hysteroscopy. Since hysteroscopy requires anesthesia, it requires daycare admission, it's a little costly procedure. Endometrial scratch can give the same result like that of uh, hysteroscopy. So, how does this endometrial scratch work? Endometrial scratch induces decidualization of the endometrium. It promotes wound healing and involves secretion of certain cytokines and growth factors which are involved in embryo implantation. It recruits some stem cells into the endometrium that creates a partially new healthy environment of a new endometrial tissue which is free of any epigenetic defects. Next, going on to thrombophilias. As I said, many thrombophilias can lead on to implantation failure. So, how do we treat? We give them low molecular weight heparin, we give low dose aspirin and Visalone. These are not very effective, but it does help to improve the pregnancy chances. Intravenous immunoglobulin as a immunotherapy. Although data doesn't show much benefit on ART outcome, there is a slight increase in the pregnancy rates. Intralipid. Again, the controlled large scale confirmatory studies are necessary to prove the efficacy before it can be recommended for a routine usage. Next, intrauterine administration of autologous peripheral blood mononuclear cells. This is all. It can also evoke an inflammatory response, producing cytokines. It can secrete proteases and regulate the endometrial function. Next, going to finding out the chromosomal abnormality in the embryos. It can identify the reason for the repeated implantation failure. It can significantly lower the live birth rate in RIF cases, but it does not improve the live birth rate. Sperm DNA fragmentation. As I said, if the DFI is high, again it could be the reason for the failure in repeated implantation failure. So, treating the male with antioxidants for 3 months can reduce the incidence of sperm DNA fragmentation and improve the chances of achieving a better quality embryo. Next comes intracytoplasmic. We usually do a intracytoplasmic sperm injection. There is another one called intracytoplasmic morphological selection of the embryo sperms for ICSI, that is IMSI. Normal, the magnification is around 400 times, but in IMSI, high magnification microscope around 6000 power magnification is used to identify the spermatozoa, which has got less vacuoles in the sperms. So only those sperms which are selected under high magnification, which has the less number of vacuoles, are selected for ICSI. So it helps this in the sperm selection. So this is one procedure which is been advocated for patients with repeated implantation failure. IMSI can be advocated for patients with repeated failures. Next, going to the patients with high DFI, high DNA fragmentation. Sperm DNA damage is lower in the seminiferous tubules as compared to that in the chorda epididymis and the ejaculated spermatozoa. So they have found a significant increase in the pregnancy rate and reduction in the miscarriage rate. Next, going to assisted hatching. See, as I said, the embryo has an outer covering called the zona. This zona or the outer shell can become thick or hard when the embryos are frozen and thawed. So, there is a uh, difficulty for the embryo to hatch and attach to the endometrial lining. So what we do, we use a laser assisted hatching where the laser lights uh, are injected to the outer zona covering, which makes the zona thin and helps the embryo to hatch. So there is a significant increase in the clinical pregnancy rate in patients with recurrent implantation failure when laser assisted hatching has been tried. Next, going to the culture condition, lab culture condition. When there is a suboptimal culture, then co-culture sometimes has been found to increase the clinical pregnancy rate. Instead of a day 3 transfer, a blastocyst transfer has been found to have a higher clinical pregnancy rate. It helps us to select the embryo, the best embryo for selection for transfer, as well as there is a better uterine receptivity with a blastocyst transfer. Next, going to the embryo transfer technique. Essentially, this embryo transfer technique should be very atraumatic. It plays a very important role in patients with RIF. It should be under ultrasound guidance with a suboptimal bladder. Embryo should be deposited in the mid-uterine cavity. And while transferring, it has to be very much gentle, and we should avoid mucus or blood or any bacterial contamination in the on the inner sheath of the embryo transfer catheter. Touching the fundus or excessive uterine contraction or blood and mucus or infection, bacterial contamination of the inner catheter can have an impact on pregnancy. So all these we can avoid by doing a trial embryo transfer. What we do is, instead of the actual embryo transfer, we just put the outer sheath of the embryo transfer catheter before the embryo transfer, even 1 month before, and check what is the uterocervical length, whether the uterus is retroverted or anteverted, what distance the embryos have to be placed, whether the cervix is healthy, at what stage we have to stop at the level of internal loss. So this is called a trial embryo transfer or a mock embryo transfer with a full bladder or a optimally filled bladder using soft catheters, so that you can select what type of catheter you are going to use at the time of actual transfer, because the time delay between the loading time and the time you do the transfer, if it gets delayed, that again has an impact on pregnancy. Next is embryo glue. The embryo glue has found to increase the clinical pregnancy rate by almost 50%. Transfer large number of embryos significantly increases the clinical pregnancy rate, but there is a risk of multiple pregnancy which has its own complications. Next is sequential embryo transfer. There is a double embryo transfer again has been found to increase the clinical pregnancy rate. Next, going to a personalized embryo transfer. What is personalized? Each woman has a window period of implantation between 19th day to 25th day of the cycle. The window period where the endometrium becomes receptive to the embryo is open. And women, they found that women with recurrent implantation failure, this window period is not constant for them. It might be displaced, it might be either early or it might be late. So in a personalized embryo transfer, you find out which is the window period of implantation for that particular woman. So endometrial receptivity array is a test which is used to determine whether the endometrium is receptive or not. So what they do is, they prepare the endometrium with either a natural cycle or in a HRT cycle. Once the endometrium grows to a good thickness, the endometrium is exposed to 120 hours of progesterone, and the endometrium is sent for testing, where some 238 genes of endometrial receptive genes are analyzed, and the report is given either as a receptive endometrium, pre-receptive or post-receptive. Depending on the result, we do a personalized. So we individualize for this patient. If it comes out like 144 hours of progesterone exposure, so instead of 120 hours, we need to expose the endometrium to extra one more day of progesterone and do the transfer. If the result comes as receptive, you follow the same protocol what you did during the ERA cycle and transfer the embryo around the same time. But if the result comes as 108 hours, that means the time when you took the endometrium for the biopsy, the window period has already closed. So you need to do it early. So that means you expose the endometrium only to 108 hours of progesterone and do the transfer. So this ERA test has been very clinically, in my practice, I feel like it has helped to achieve result in many patients, because the window period of implantation is not the same for women who have multiple failures. ERA helps to identify the window period. It's not that we are putting an abnormal embryo, we are putting the embryo at the wrong time. So we need to know the exact time we need to put the embryos. So this personalized embryo transfer performed on the day designated by the ERA, there is a 50% increase in the pregnancy rate and 38% increase in the implantation rate. Next, going to the multifactorial factors. Lifestyle changes is very important. One is like, even though the patient might be, they might say that we have only one or two cigarettes per day, but even that has an impact on the sperm quality. Smoking, alcohol, and obesity, high BMI, all this has an impact both on the oocyte as well as on the sperms. So lifestyle modification is very important from the patient side. Next, going to the hydrosalping. Hydrosalping is what? It's a swollen and unhealthy fallopian tube which is filled with a fluid. This hydrosalpinx fluid, they found that in two ways it can have an impact on pregnancy. One, the fluid, if it seeps inside the uterine cavity, it can flush out the embryos. Second, that fluid can be toxic to the embryos. So, if a patient has a suspicion, if you have a a suspicion that the failure could be because of a tubal factor where there is a suspicion for a hydrosalpinx, better do a laparoscopy, confirm that there is no hydrosalpinx, and then go ahead with the next transfer. But if there is a hydrosalpinx documented and if the tube is patent, they found out that patients who had a salpingectomy before the next embryo transferred, the clinical pregnancy rate and live birth rate almost double compared to patients who didn't have a salpingectomy. Next, endometriosis. Treating endometriosis, depending on what stage of endometriosis, stage 3 or stage 4, very bad endometriosis, preparing them for IVF with 3 or 6 cycles. Usually, we give at least 3 cycles or 3 doses of GnRH agonist injection to shrink the endometrioma, increases the clinical pregnancy rate by almost fourfold. So, long protocol works better in women with endometriosis. But as such, there is no effect of removing an endometrioma before IVF. Next, going to the protocols. What protocol you follow for what kind of patient? So the dosage of injection, what you give, also decides the oocyte quality. So tailoring the stimulation protocol to individual patient based on the age of the patient, based on the body mass index, based on the AMH level, based on the antral follicle count, the size of the antral follicle count, tailoring the dosage, and seeing after 3 days or 4 days of injection if there is a suboptimal response, adding a HMG injection or LH injection, all that will improve the result. So tailoring the stimulation protocol based on the we decide the protocol even based on the previous response. In the previous cycle, what was the response after 3 days of injection? How did she respond? So depending on that, we decide the protocol. So this tailoring the stimulation protocol based on individual patients' response, based on individual BMI, antral follicle count, age, and AMH, improved the blastocyst quality as well as the pregnancy outcome in patients with RIF. Next, in there is a poor response. In spite of adding FSH injection, there is a poor response. Then what we do? Add HMG injection. When patients who are above 35 years of age, starting with HMG injection along with FSH improves gives us a better result. As I said, there are few more treatment protocol which we do, but there are no RCTs to prove that changing any stimulation protocol can improve the outcome. So now recurrent implantation failure is a huge topic. But when you look at 1 or 2 failures, then before starting the next stimulation, we need to identify or trying to find out the cause. As I said, whether it is from the endometrium or it's from the oocyte or the sperm or it's a multifactorial. So try to find out the problem and try to correct. From the endometrium, either do a hysteroscopy or a myomectomy, or if there is a fallopian tube, if you have a suspicion for hydrosalping, then do a salpingectomy. Or if you feel it's a thin endometrium, give adjuvants to try to improve. If the endometrium remains thick in spite of all the adjuvants, then even a natural cycle frozen embryo transfer can have a better result. And if the patient has a good endometrium, good quality embryo, then finding out the window period of implantation by doing a ERA test and then doing a personalized embryo transfer, doing a blastocyst transfer, or if there is a severe poor ovarian reserve, changing the gamete. If the couple are okay with the donor oocyte, then you can change the gamete and see. And in the if there is a lifestyle habit, if there is a history of smoking, obesity, alcohol, then check the DFI, and if it is high, treat the husband with antioxidants and then go ahead. Or you can even do a karyotype when there is a severe male infertility. And all these different methods. Then if there is a severe poor quality embryo which is obtained, we can do a pre-implantation genetic testing to find out whether it is euploid embryo, then plan a transfer. Many known and unknown reasons are there for recurrent implantation failure. There are a lot of tools available. So we sometimes get confused which test to do for next. And we need to sit and analyze what all can go wrong with the patient. What could be the reason it went wrong. Then looking at autoimmune diseases, thrombophilias, Apla syndrome, SLE, all that helps to rule out the immunological causes. After the failure of 2-3 transfer of good quality embryo in a unit with a clinical pregnancy rate of more than 30%, we need to take extra precautions and try to find out what is the reason for RAF. Again, as I said, the management of RAF is individualized and a multidisciplinary approach. You can even get a second opinion from one of your senior consultant or a senior embryologist to look at the embryos and find out what could be the reason. So, as I said, hysteroscopy procedure, endometrial injury, administering autologous PBMC, laser assisted hatching, salpingectomy, embryo glue, so many things are there. And using adjuvants to grow a good endometrium, aspirin, heparin, immunoglobulin, Visalone, intralipid, co-culture, using vaginal sildenafil, transferring a blastocyst, transferring in a natural cycle, frozen embryo transfer, and to rule out you aneuploid embryos, pre-implantation genetic testing. So these are the various investigations we do to prevent a failure in a patient who has a recurrent implantation failure. Try to find out the cause and try to correct it. Thank you.